So with that, I would like to invite our first presenter to the stage. Our first presentation is entitled Comparing Extended Release Injectable versus Sublingual Emergency Department Initiated Buprenorphine on the Treatment Engagement. This is presented by Dr. Gail D'Onofrio.
Thank you. I'm very excited to be here on behalf of a very large team of ED innovation investigators and the NIDA Clinical Trial Network. I have no conflicts of interest. The 7-day injectable was given by the company to NIDA and then directly to us. So as you know, that ED-initiated buprenorphine is effective for the treatment of OUD, yet there is very widespread adoption lags. And this could be from results from barriers from ED clinicians and thinking that there's lack of ability to promptly access treatment, to patients who have lots of medical logistical problems with getting insurance, getting transportation to these areas, and often 50% of them present with minimal withdrawal and inability to start buprenorphine, as well as their fear of precipitated withdrawal. So it's possible that a medication that could help with some of these concerns may advance the adoption. So it's helpful to know a little bit about the pharmacokinetics of both of these formulations. If you look at the graph there on the left, it shows you the plasma concentrations, and that first hump is really from the sublingual, which rapidly rises in the plasma and then decays over 12 hours or 24 hours. If you look at the XR bup, what you see is this gradual increase so that you get to only about 1.6 nanograms per milliliter at 4 hours, and then it progressively escalates and stays elevated for a total of 7 days. So from that, ED Innovation was born. It was a randomized controlled trial looking at both this XR 7-day buprenorphine and the sublingual bup induction in approximately 2,000 ED patients. XR bup was done under an IND protocol, which was called CAM 2034 at that time. We enrolled in 29 sites throughout, really geographically diverse around the country, from, as you can see, just about when COVID started through 8/24. Our primary outcome was to compare the effectiveness of XR bup and SL bup induction on engagement in formal addiction treatment at 7 days. Formal addiction treatment is clearly defined by the SAEM criteria 1 through 4, which goes from a simple outpatient to medically supervised intensive therapy. We have a lot of secondary outcomes, and I'll go over each of those. Our inclusion criteria included all those individuals who were 18 years of older who met the DSM-5 criteria for OUD. We started with those that had a clinical opiate withdrawal scale of greater than or equal to 8, and I'll talk to you later. We were able to expand that to greater than or equal to 4. They had to have toxicology positive for an opiate and be able to speak English. Our exclusions were that they could not have a positive urine for methadone, they could not be pregnant, they could not be in formal medication for opioid use disorder treatment within the past 14 days. They could not require hospitalization, suicidal or actively cognitively impaired, or be a prisoner as usual. So our intervention was that for CALs initially greater than or equal to 8, the individual received, if they were randomized to XR bup, 24 milligrams as a sub-Q, very tiny injection. It is equivalent to 16 milligrams a day, or they started with a sublingual dose of 8 milligrams of buprenorphine and followed up with a prescription for 16 milligrams a day until they could reach their first appointment. Along with this, in parallel, we did an ancillary study that has already been published. These were by 4 different sites with very experienced emergency physicians and who were boarded in addiction. We were looking at could we use XR bup in very mild cases to no withdrawal. So that was from 0 to 7. Within a year, we found out that actually we could enroll patients who were 4 to 7. They had very low incidence of precipitated withdrawal. And so our DSMB allowed us to change our strategies for intervention. And those that were CALs 4 to 7, if they were in the XR bup group, they received the injection. If they were in the sublingual group, they got instructions for unobserved induction. Our sample size and analysis was built around a size of 2,000, which would give us an 8% difference in proportion engaged in treatment at day 7. Engagement in treatment was verified at 7 and 30 days. It was first self-report, and then it was verified by the treatment facility. We used this process called GEE, which really helped us to mitigate any potential bias for dropout. It also adjusted for pre-specific covariates that we thought were associated with engagement, which were age, race, sex, ethnicity, insurance status, housing status, and the site. So what are our findings? First of all, this is the huge consort diagram. We screened over 188,000 patients. The vast majority of those screened out because they didn't use opiates in the last 30 days. And then we looked at other things, but only around 6,000 people refused that initial screening. We ended up with 2,023 that were eligible for screening. 23 of those were not randomized because they either most likely refused to be randomized, they were admitted, or they left the ED. That left us with 2,000. 6 of those people were randomized twice, we found out. That left us with a sample size of 991 in the XR Bup and 1,003 in the sublingual Bup. And our primary outcome, as you see, was very good, 86, 87% in both of those fields. In terms of the baseline characteristics, they were pretty much equal in all of the groups. They were mostly male, 68%. They were a pretty diverse group in that 55% were white, 30% black, and 15% identified as Hispanic. They were mostly unemployed, as you can see here, 63%. They were also a very vulnerable population in that 51% identified as having unstable housing in the past 12 months, and 37% were currently unhoused. 75% had public insurance, 76% had fentanyl in their urine, and 77% had more than one drug besides an opiate. Now, getting on to our primary outcome, as you can see here, and I'll look mostly, we're showing you both the unadjusted and the adjusted with the GE modeling, and we'll look particularly at the adjusted model, is that 40% or 40.5% in the XR Bup were in formal addiction treatment at day 7, and 38.5% were in sublingual buprenorphine. You can see this was non-significant between the groups, but the really good news was that almost 40% were in treatment at 7 days. Now, if we broke down that 7-day engagement in treatment according to their CAL scores, you can see there on the bottom in the adjusted phase, is that here 40.1% were in treatment if they had a CALs between 4 and 7 in the XR Bup, and 34.7. And while this was, a 5% difference, it was not statistically significant. But one would expect in that group that patients would do well if they got an injection, because it would be direct to inject right there, as opposed to getting a prescription, going to the pharmacy, and using it on their own. I do want to note that this subgroup analysis was not sufficiently powered in the beginning. This was around 530 patients in this group, and so we did not initially power it to look for a change in there. But we did see, as you can see, a pretty good trend there. When we look at day 30, we did not find any significant differences between the two groups. Again, though, surprisingly, 40% of patients were still in treatment. These could be different patients, but 40% of patients were in treatment at 30 days. We then went to look at a lot of different characteristics to see whether there was any differences between comparing those groups of XR to sublingual in that 7-day period. And so we looked at all these demographics, odd ratios, of which we did not find anything. We also looked at lots of other characteristics, of which we also did not really find any difference. It looks as though current housing, unstable housing, or having stable housing might be a good thing, but that really crossed 1, so it was not significant. We looked at craving scores at day 7. These ranged from 0 to 100. Again, you can see that the craving scores were consistently lower in the XR group than the SL group, with medians of 10 to 15. And those that reported 0 cravings in the XR group were 40 compared to sublingual 35.4, but these were not statistically significant. The same with self-reported illicit opiate use. We were surprised to see in both groups at 7 and 30 days that very few people did use opiate use of any of those days in the 7 days. And this was all done by the timeline fallback method, so it's pretty good. We had about 84% of patients who were able to give us data for this. If you actually put in and decided and did some kind of analysis that all those individuals who didn't tell us that they were not in, that we could not get a hold of, if we decided to impute them as using those days, this would only go down to about 60%, so it's pretty good data. In terms of overdoses, you can see initially that people had reported a fair amount of non-fatal overdoses in both groups. At 7 days, those were substantially less, but not different between the groups, down to 8. And at 30 days, which is inclusive of those 7 days, there were 26 in each group. Again, no difference between them. Other adverse events that people always think about are precipitated withdrawal. And you can see here the circles represent all of the 29 sites, and the stars are the places where precipitated withdrawal occurred. The green are the sublingual group, and the blue are the XR group. And you can see that there are very few of those. We had less than 1%. As you can see here, 6 in the XR bup, and only 8 in the sublingual group. So 14 overall of really those 2,000 patients who were given buprenorphine. We asked about patient satisfaction, and patients reported their overall experience with treatment on a scale of 1 to 5, 1 being completely ineffective and 5 being completely effective. And here we did see a substantial increase in XR bup, and it was statistically significant. Their medians were actually 5 compared with 4. And we used the treatment effectiveness assessment scale, which was developed by Walter Ling. This allows us to understand the real complexity associated with opiate use disorder, and it lets the patient talk about from their perspective, their progress along their treatment path. And you can see here it has 4 domains: whether substance use, how much better are you with drug use, feel better with your drug use, how's your health improved, how much better are you at taking care of personal responsibilities, and then with community or a better member of the community. And all of those domains, patients who were in the XR group were significantly much better than those that were in the SL group. So conclusions and implications. XR bup and SL bup were administered to approximately 2,000 patients in 29 diverse EDs across the US. We were able to do this. There was no difference between these outcomes in the majority of them. Although 40% of individuals were in treatment at 7 and 30 days, there was a less than 1% that experienced precipitated withdrawal. XR bup did allow us for individuals to engage with direct access to bup at very low levels. So again, this was ability to directly inject buprenorphine at the time of the ED visit. This all allows us to advance individuals along the cascade of care and gets people into treatment faster and saves more lives. So the last thing is I'd like to thank all these tremendous amount of people that were our investigators. There were huge amounts of people, and if they're there, I would really like you to stand because you really made this possible. These are all of our PIs. And these are all of our leadership team at Yale who are here too. So please stand up.